invoke the blessing of Almighty through lighting a lamp on a virtual platform, which is not only a symbolic gesture, but also a profound expression of gaining knowledge, for which I request Mr. Arun to do the needful. Mr. Arun.
Sonia madam.
Sonia.
So I think madam has lost our connection.
Yeah.
Yes, sir.
Okay. On behalf of Sonia, the convener of the program, I once again invite our chief guest, Dr. Kiran Kurtkoti, guest of honor, and our own president of KCOG, and Dean of KCOG, Dr. M.B. Bellad, chairperson of KCOG, Dr. Vidya Bhatt, and all the three KCOG Yuva program speakers and all those who have joined for the program. I request our Dean, Dr. M.B. Bellad, to address. Dr. Bellad.
Hi, good evening, everyone. And ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. Dr. Kiran Kurtkote, Dr. M.G. Remat, and all the office bearer, Vidya Bhatt, and the esteemed speaker, and my respected KCOG members. It's indeed a proud privilege for me to be there for this. Very important sessions are being covered, and it will be nice to have this. And because without taking much of the time, I want to see that these sessions are dealt very nicely, because they are very important and real burning problems, especially puberty menorrhagia. We are seeing the young girls coming with this, and that is causing the anemia in the adulthood. And also the important topic, which is now the important killer of our pregnant woman, that is hypertension. And last but not the least, give life to, the life beyond the menopause. And that is what is going to be addressed in the menopause, to let them have a fruitful menopause and enjoyable one, because it is said that life does not stop at menopause. It in fact begins at the menopause, because these are the women who are invited for every event. So we have got a beautiful 3 sessions which will be covered in this. I thank Dr. Sonia for organizing this, and I also thank Dr. Kiran and Dr. M.G. Remat and all the members and all the speakers to do this wonderful webinar. Thank you so much.
Thank you, Dr. Bella, sir. Now I request our chairperson, Dr. Vidya Bhatt, to introduce our esteemed chief guest, Dr. Kiran Kurtkoti.
Good evening, everybody. Respected patron of KCOG, M.G. Hiremat sir, our Dean Bellad sir, and our dynamic secretary Sonia, and all the esteemed KSOG and KCOG members. It's a joy to introduce our chief guest today, Dr. Kiran Kurtkoti. He's not somebody unfamiliar to us. He's been our guest since 2009. I don't know whether if sir remembers this. 2009, when we did KCOG conference, Kiran sir was there with us and he had done a session. So it's a long association with Kiran sir and KCOG. So it's K and K. So KCOG, a lot of bonding we have. And since then, he has been a role model for us in so many things. And I was just listening to what all he has done, achievements as a AMOX president. So it's great, sir. Congratulations to you. So just a few words about him. There's a lot to tell, but in short, I'm telling you, he has been the MTP committee chairperson. That time he had visited us. Then AMOX chairperson, joint secretary, and in medical education and MTP committee. Then
Dr. Vidya, it's okay.
Yeah, there is so
That's
much.
okay, fine.
And director of Shashwat Medical Center. Then he's a recipient of so many awards and publications he has, and of course, a lot of lectures. That's basically because of his iconic appearance. So, hearty welcome to you, sir. And may I request you to give your chief guest address?
Thank you. Thank you so much. Namaskara, everyone in KCOG. Dr. MG Hiremat, patron not only of KCOG, but patron of so many people. I mean, the other day when I was at another webinar, I said that when I joined Foxy, if you are blessed by one person in Foxy, that is Dr. Hiremat, then you are through. Okay, so that is the aura and that is the power of Dr. MG Hiremat, you know. So thank you, Dr. Hiremat, sir. So when he called me, he said, Kiran, today is a very auspicious day. Today is Basava Jayanti and you have to come. So I said, yes, definitely, and I will come. And such is the power of Dr. Hiremat that I had logged in yesterday itself. And he told me that no, Kiran, it is not yesterday, it is today. So again, I have logged in today. So thank you, sir. Thank you for that warm affection and love that you've shown to me. Actually, as Dr. Vidya rightly said, my association with KCOG is not now, but my ancestors, we belong to a very small place near Gadag. So there's a very small place near Gadag, which is called as Kurtkoti. So we belong to that particular place. So then we migrated to Maharashtra, and that is how I got separated from KCOG. Yeah.
Roots are from Karnataka.
Very, very strongly from Karnataka, because my mother is from Belgaum. She is from Deshpande Nagar, Belgaum. My dad is from Hubli. And so that's how we are.
Fully Karnataka.
Yeah, fully Karnataka.
Fully Kannadiga.
Yeah, fully Kannadiga. So anyway, thank you. The Dean, Dr. Bellad. Bellad is a very old friend. Vidya, again, our friendship dates back to 2009, as you rightly said. Dr. Sonia, I see a lot of known faces. I have Dr. Vidya is there, Toby is there, Dr. Rajeshri Paladi, Dr. Suvarna, and so many people. So thank you for inviting me to be the chief guest at this particular webinar. And I really look forward to all the topics. Dr. Bellad has already said. One is about the menopause. You have involved all the three committees. So one is the menopause committee, the medical disorders committee, and the IVF committee. So I look forward to this particular webinar, and thank you once again to all the entire KCOG, the KCOG office bearers, and all of you, very lovely people, for involving me as the chief guest. I'll always remember whenever any of you comes back to Pune, or any one of you decides to go ahead in any of the organizations. Thank you so much, and bless not only me, but my society and my state people in all your forums. Thank you. Thank you so much.
Thank you, Kiran. Thank you. Sonia, you can take over.
Thank you so much, sir. And sorry for the technical problems I had to face now. So we move ahead, and yes, Kannadiga.
Bharti has not joined.
MG, just one word I want to tell about Kiran Kurtkoti. The MTP Act and legal, requirements and what must be known. Actually, Kiran came to us we did a workshop on medical legal. Workshop was done, and he, along with his other colleagues, they came and they really addressed and made aware through KCOG. Many of our KCOGians are now aware of these MTP Act. The first credit goes to Kiran Kurtkoti when he was a MTP committee chairman.
Thank you. Thank you,
Dr. I would like to add one more. When Kiran was invited to Hubli conference, they missed the luxury bus. He came by red bus.
Yes.
You can imagine how much he has
Yes.
got affection for the scientific programs and for the Karnataka.
Yes, sir. Yes, sir. I remember that. That was way back. Yes, sir. Thank you.
Thank you, Dr. Kiran Kurkoti, Kannadiga. Let
Thank
me
you.
address you on this platform for a minute like that. And
Yeah.
thanks for your presence, sir. It adds immense value to this virtual platform. And moving ahead, our guest of honor today, Dr. Bharti Rajshekar, President of KCOG, probably will try to join us in this platform. But in her absentia, it is my duty to thank her and also welcome her and also convey our best wishes for her for the forthcoming elections too. Madam has just sent a message that she is in Jeju. I think she is enjoying her academics as well as the touring of the place. In case if she joins, maybe we'll address to it. Moving ahead, we now start with our scientific session. As mentioned, we have 3 speakers. For this, may I now request our Chief Patron of KCOG, Dr. M.G. Hiremat. On behalf of all members and with due respect, it's my privilege to extend a heartfelt thanks and a welcome to the pillar of KCOG, a guiding force. As a leader of academia, your wisdom, sir, is a guidance, and it's helped lot many budding gynecologists. The concept of yuva, yes, you've made us understand 40, 45, less than 40, and you've created a platform for the junior consultants to groom ourselves. And KCOG is a very good platform for the yuvas to be grooming and to reach to the further heights till the Foxy and the international level too. We are honored to have you with virtual space, sir. Yes, we move ahead. And
only 1 minute, because I'm very particular that all this should be ended in 15 minutes.
Yes, sir. So over to you to continue with the scientific deliberations.
Thank you. Thank you. Once again, I would like to thank our chief guest who has made this program a very interesting, and our dean and the chairperson. And I request all of them to join on every Thursday, because your presence is very, very essential. And that will give and add color to the program. And it will also add knowledge in the program. So that's why all the KCOG office bearers must be there. And Kurtukoti sir can remain if he is free. Otherwise, if he has got another webinar, I request him to take off. And Kurtukoti sir, this is what we have done this year.
Yes, sir.
We have 20 committees. And all the committee chairpersons were feeling that they are not getting the platform. And they were only used as a convener. They were not invited as a speaker. So this year, first program only I have decided that 3 committee chairpersons will be given the opportunity to be the speaker. And that's how today we have got 3 chairpersons, and all the 3 chairpersons are very, very dynamic. And they are so dynamic that they are capable of running the show on their own. But only thing is that I have given them a very short time, not more than 20 minutes. When 15 to 20 minutes, they have to cover a very small portion of a topic. And this is definitely will help the practitioners, number 1. Number 2, the postgraduates will also pick up, because a small topic we have selected, like just hormonal management of menopause, or management of only severe hypertension, or only oocyte freezing, because all 3 are very good in this subject. So we thought that, and they are all less than 40. So now onwards for the whole year, every 3rd Thursday is reserved for yuva. The speakers will be yuva only, and they will be given an opportunity to address. And today, the first speaker is none other than ever smiling Dr. Sanjana Patil. Can I have her biodata? When the biodata was requested, we just put up them that please give 5 important your achievements. Then I heard that Sanjana Patil told, I will give only 2. One is my name, another is my chairperson. I know Sanjana very well, because I also come from the same place, a very, very popular gynecologist. And ethically practicing, made very good name. She is the faculty in the medical college, and in the last 2-3 years, she has made lot of impact in the KCOG academic programs. And when we had offered her to be the chairperson of the menopause, she has conducted many programs today. And the topic also we have not impinged on them. I have told them that whatever topic you are comfortable, you take the topic. And in a short time of 15 to 20 minutes, they can give their the views. And later on, we have got another 15-20 minutes for the questions. And I request all the delegates to put up their question in the question bar. And Dr. Rajeshri Paladi will take up the question session. So next 1 hour, we are not going to interfere with the speakers. Every speaker has got an opportunity. And we'll start with Dr. Sanjana. Now, Sanjana, the platform is yours.
Thank you, sir. Thank you. I'll share the slides, sir, first.
Yes.
Sir, namaskara ellarigu. Thank you, sir, for my brief introduction. I thank Hiremat sir for giving me this opportunity to talk on this platform. I thank KCOG Dean Dr. Bellat sir, Chairperson Dr. Vidya ma'am, and Secretary Dr. Sonia ma'am. And I thank my greetings to today's chief guest Dr. Kiran Kurtkoti sir, and our beloved President Madam Dr. Bharti Rashekar Madam, and our KCOG Secretary Dr. Rajesh Paladi ma'am. So without wasting time, I'll begin my topic. Today's topic is conventional hormonal therapy for menopause, which I have chosen, sir. The real age of discovery does not exist in seeking new landscape, but having new eyes. That is, we should have a new eyes towards our own hormone, estrogen and progesterone, towards treating menopause. So if you go by history, the first prescription of hormone therapy was given in the form of sheep ovaries. Later, the ovarian extract were used for relieving menopausal flushes. In 1941, FDA approved the use of conjugated estrogen in postmenopausal women for treatment of symptoms. Since then, the prescription of hormonal therapy by professional and uptake in the postmenopausal time period has been a roller coaster ride. Phases of increase and decrease in hormonal therapy usage, depending upon the various clinical trials, are still being analyzed and debated upon. The information from WHI and new thoughts about hormonal therapy, thorough multiple trials have evolved and are still evolving. It has also likewise cleared some gray areas and has reinforced the beneficial effect of hormonal therapy, as seen in many observational trials in the past 3 decades. The terminology which are used in hormonal therapy are menopausal hormonal therapy or hormonal therapy, which are interchangeable. If the hormones were used as a replacement in premature menopause, then it is hormonal replacement therapy, estrogen progesterone therapy, and androgen therapy. There is a drastic shift in the use of hormone therapy from earlier times as compared to now, which we can conclude from many studies that have been conducted over time. Before, it was considered for prevention and generalization, but now the keywords are like symptom relief and individualization and the tailoring of doses. This slide explains or says about the present usage of hormone therapy and the past usage of hormone therapy. Like the hormone therapy was considered for all postmenopausal women in the past, now it is a selection of the women and for their symptom relief. And it should be used within 10 years of menopause or within 60 years of the age. Before, it was for a long-term use, now the short-term use is considered. It was thought that hormone therapy may offer cardiovascular disease protection in all ages, but now the risks are more and are not to be used solely for primary or secondary prevention in cardiovascular disease. There was a standard combination, fixed doses, and continuous combined regimes were used before, but now detailed formulation, minimal effective, tailoring of the doses, and low doses are used. Oral route was preferred before, but now transdermal route is under consideration. It was considered that all types of estrogen and progesterone therapies had increases the risk of breast cancer. But now it is considered that with estrogen alone, there is no increase in breast cancer. Use of natural progesterone may not increase the incidence of carcinoma breast. The hormonal therapy is benefited if it is used within 10 years of menopause and within 60 years of age. there is a lack of safety data supporting menopause hormone therapy in the use of breast cancer survivors. And the hormonal therapy on both, if it is used between the age 50 to 59 years, it is safe, cost effective, and it is effective in preventing osteoporosis related fractures. So the hormonal therapy solely for prevention of chronic disorder is debatable. So while prescribing a hormonal therapy, the physician should consider the following things like benefit, risk, side effect of hormone therapy, types of hormone therapy available along with options suitable for patient, the method with which the patient treatment will be monitored, the duration of hormone therapy, economic consideration, obtained informed consent and make notification about the high risk issues. We need to assess a profile of a woman and individualize the treatment depending upon the detailed history, type, stage and type of menopause, evaluation of women's need and preference, evaluation of women's individual risk factors. Risk stratification is based on the following factors like age, time since menopause, and comorbidities. General condition of the patient should be assessed before starting the hormonal therapy, like physical examination, her pulse rate, blood pressure, weight, height, pelvic examination, and breast examination should be considered. And investigation like complete blood count, routine, urine routine, fasting glucose level, lipid profile, serum TSH, stool for occult blood, pap smear, TVS, TAS, and mammography. And it is very mandatory to do ophthalmic examination when we start a hormonal therapy. To know the intraocular pressure, we do tonometry, refractive index measurement, and the retinal test. Based on these assessment, women can be classified into specific category which help in the management of a patient. She may be healthy with no risk factor, healthy with risk factor, healthy with latent disease, and healthy with overt disease. Some precautions are to be taken while we prescribe a hormonal therapy, like age. As I'm saying repeatedly, it should be started within 10 years of menopause or within 60 years of age. And low dose hormone therapy is considered, low dose of estrogen and low dose of progesterone. And the transdermal route is very considered nowadays as, or when there is a risk for blood clotting, or in case of VTE. Consideration of progesterone, that is newer generation progesterone, mainly drospirenone or natural progesterone are considered. They are good in case of hypertensive patients also. With uterus, progesterone adequate dose is given along with estrogen, and without uterus, estrogen alone is given. So vaginal estrogen application does not need the progesterone support. If there is a undetected bleeding, it should be investigated with ultrasound and endometrial biopsy. Screening tests with annual follow-up are essential when prescribing the hormonal therapy. The tailoring of doses should be considered. Risk and benefits of the individual patient should be considered. Full medical assessment is necessary before we start a hormonal therapy. So like how we do a follow-up in a patient when she is on hormonal therapy, ask her to come after 1 month to know the efficacy and side effect of the hormonal therapy. And after 3 months, for the assessment of effect of compliance, and annually for physical examination, update of medical family history, lab investigation, imaging, and lifestyle discussion. Some contraindications for hormone therapy are active endometrial and gynecological hormone-dependent cancer, active breast cancer, estrogen progesterone receptor positive cancers, known suspect pregnancy, undiagnosed abnormal vaginal bleeding, severe acute liver disease with impaired or abnormal liver function, previous personal or family history of VTE and SLE. Some relative contraindication like migraine headaches, superficial thrombophlebitis, strong family history of CA breast, uterine fibroids, endometriosis, and gallbladder disease. So when we need to stop the hormonal therapy, if the patient complains of severe migraine, if it appears for the first time and it gets worsened, and if they have a blurring of vision which suggests of a vascular occlusion, then we need to stop a treatment. If there is appearance of a jaundice, if there is an increase in her blood pressure, then we need to stop a treatment. And before taking her for any elective surgery, we need to stop a hormonal therapy 4 to 6 weeks before. So certain drugs are there which interferes with or which interacts with this hormonal therapy, like it enhances the effect of imiparin, phenytoin, and carbamazepine, and reduces the effect of anticoagulant hypoglycemic agents, increases the metabolism in drug like rifampicin and barbiturate, and increases the level of TBG. So these are the consideration for the estrogen progesterone therapy. Like in surgical menopause, estrogen therapy is used or the tibolone is used. In perimenopausal, cyclic progesterone or OCPs or hormonal therapy cyclic is used. In early menopause, if it is less than 12 months, estrogen progesterone therapy, which more estrogen should be considered in a sequential pattern. In the late menopause, if it is less than 12 months, estrogen progesterone therapy where the low estrogen or the transdermal estrogen is preferred. In premature menopause, OCP or a hormonal therapy sequential regime is preferred. And in urogenital atrophy, local estrogen is preferred. So these are the regimes which are normally used in hormonal therapy, like cyclic combined, continuous cyclic, continuous long cycle, continuous combined, and intermittent combined. These are the days where the progesterone and estrogen can be given. So if the estrogen is given from 1 to 25 days and last 10 to 14 days, progesterone can be added. So in case of perimenopausal women, it is always necessary to give a hormone in a sequential doses where the estrogen is given for 1 to 25 days, then last 10 to 14 days, progesterone is added. If we give a continuous regime in a perimenopausal woman, then there are chances of breakthrough bleeding. Whereas in postmenopausal women, we prefer to give a long continuous regime where daily estrogen and progesterone are given. Here, daily estrogen is given, and last every 3rd to 6th month, we can add a progesterone, which helps in suppression of the endometrium. So these are the doses which are these are the doses and the types of estrogens which are considered in hormone replacement therapy, like conjugated equine estrogen, which is by oral route, 17-beta estradiol, estradiol valerate. All these are oral route, and transdermal 17-beta estradiol is through transdermal route. Ultra low, low, standard, high. All these doses are considered, but the most preferred one is low dose estrogen. Why we prefer the low dose estrogen? Because one-time hormone therapy cannot fit all population of postmenopausal women. Benefits of hormonal therapy can be maintained with lower doses than previously used while minimizing the risk and possible side effects. Improved continuous and compliance to achieve potential long-term health benefits, and efficacy in prevention of osteoporosis is not compromised. Some exceptions to low-dose therapy are premature ovarian follicle, severe osteoporosis, and predominance of psychological problems like climacteric depressions. What are the routes which we administered in hormone therapy? Are oral, like low-dose hormone therapy is preferred. Vaginal is indicated for urogenital symptom, and transdermal is indicated in migraine, diabetic, triglyceridemia, hyperlipidemia, increased CRP, controlled hypertension, obesity, smoking, varicose vein, VTE, or when the patient recommended. So some adverse effects are like fluid retention, headache, bloating, breast tenderness, mood changes, and nausea. All these adverse effects are transient and they may get resolved within 3 months. So assurance and counseling to the patient is mandatory when we start a hormonal therapy. So if the patient comes to us with a bleeding problem when she is on hormonal therapy, it may be due to a persistent ovarian activity, which we need to alter the dose of estrogen or the progesterone, and if it continues, then we need to investigate her. We should evaluate the postmenopausal bleeding in patient who is taking hormonal therapy, because always there is a risk of endometrial hyperplasia or carcinoma endometrium when she complains of bleeding when she is taking hormonal therapy. There is a myth that when she is on hormonal therapy, there is a weight gain, but Cochrane analysis says that there is no difference of weight gain in a woman who is on hormonal therapy and who is not on hormone therapy. So the management of patient with persistent symptoms, we need to evaluate the specific problems, identify the improved symptoms, and identify coexisting medical, social, psychological, and sexual difficulties. By seeing all these things, we can alter the dose of estrogen, change the type and route of estrogen, decrease the dose of frequency of progesterone, change type of progesterone and formulation, change time of medication administration, add additional non-hormonal medication, add androgen, this is not available in India, and Bibilon can be added. For how many years we need to use this hormone therapy? Safety data says that estrogen and progesterone can be used for 3 to 5 years, and safety data of estrogen therapy is for 7 years with 4 years of follow-up. In case of premature menopause, hormone therapy can be prescribed up to the natural age of menopause. So how can we stop? Means we need to stop it abruptly or gradually. We can follow either of it, or we can decrease the dose of estrogen in the pill also. So coming to the progesterone and androgen, progesterone or progestogens have been primarily used in hormonal therapy to prevent the risk of developing endometrial hyperplasia and malignancy. Some indications of progesterone are in non-hysterectomized patient to protect the endometrium. In hysterectomized women, residual ovarian tissue like endometriosis and frozen pelvis, residual endometrium, endometrial ablation, and supracervical hysterectomy. So the route of progesterone are oral, vaginal, or intrauterine implant. The types of progesterone are progestogen, dydrogesterone, or levogestrone. Here, the newer generation progesterone or the natural progesterones are considered for hormone replacement therapy. The patient characteristic that may be favorable for estrogen and androgen combination are surgical menopause, continued vasomotor symptom despite estrogen replacement, acquired sexual desire function. In India, androgen formulation for the use of menopause are unavailable, so Tibolone is a good alternative. So the benefits of hormone therapy are like the three most beneficial effects of estrogen are symptom relief, urogenital symptom relief, urogenital atrophy. The most effective treatment of vasomotor symptom is hormonal therapy. In hormonal therapy is vasomotor symptoms. Grade A because there are recommendation and suggestion by some International Society of Menopause, Indian Society of Menopause, or Endocrine Society. All this says that when the hormone is given for the treatment of vasomotor symptoms, then it is quite good. So the progesterone or low-dose oral contraceptive pills can be used in menopause transient phase for the relief of symptoms. And vaginal estrogen therapy is the most effective in the treatment of urogenital atrophy. Some estrogen progesterone therapy and estrogen therapy can be used to reduce the risk of spine, hip, and other osteoporotic fracture by 33 to 40%. Hormone therapy for bone protection within 10 years of menopause is very useful. Estrogen can be prescribed to enhance the mood in women with estrogen deficiency related depressive symptoms. The effect appears to be greater for perimenopausal symptomatic women than for postmenopausal women. So the possible effect of hormone therapy are it decreases the risk of type 2 diabetes, decreases the abdominal obesity, estrogen protective effect of osteoarthritis, estrogen benefits verbal memory over the short period after surgical menopause and reduces the neurovascular macular lesions. So tips of hormone therapy, like if it is given within age of 50 years, benefits of HRT for overweighs the risk. So HRT should be offered if she is less than 50 years. If the woman is between 50 to 60 years with menopausal symptoms, then benefits the HRT overweighs the risk. If she is more than 60 years, benefits the HRT equals the risk. So treatment should be individualized. If she is more than 70, the risk tend to overweighs the benefit. So some guidelines are there by Indian Menopause Society, International Menopause Society, and North American Menopause Society. As I said you earlier, if it is given within 10 years of menopause or within 60 years of age, then it is considered as quite good. So the duration of use is in premature menopause hormone therapy up to natural age of menopause, that is 3 to 5 years is considered. Continuation of the therapy should be decided at the discretion of the well-informed women and her health professionals. So monitoring, already I have said that the pre-hormonal therapy workup and initial after 1 month, 3 months, and annual follow-up is done by, and it is considered by all societies also. In case of osteoporosis, estrogen, as said by Indian Menopause Society, estrogen progesterone therapy or estrogen therapy may be used for prevention and treatment of osteoporosis in early postmenopausal and symptomatic women. Estrogen therapy and progesterone therapy prevents all osteoporotic fractures even in low-risk patients. All this society also says that, like the International Menopause Society, North American Menopause Society, all this says that if the hormone is started within 60 years of age or within 10 years of menopause, then they have a very good effect on preventing osteoporotic fractures. So coming to the cardiovascular diseases, all three societies says that no or lower risk in a healthy woman less than 60 years of age or within 10 years of menopause. So on the breast cancer, so progesterone plus estrogen may not increase the risk if given within 5 years or for less than 5 years, which is said by Indian Menopause Society. But in one society, that is in the International Menopause Society, says that there is a small risk, there is an incidence of less than 1% by 10,000, 1,000 women per year of use is there when given estrogen and progesterone in a breast cancer woman. So my take home message is target population for hormone therapy is usually within 10 years of menopause. Hormone therapy initiated in early postmenopausal period in women is safe, that is within 60 years of age. Low dose hormone therapy is most preferred and accepted. Like all medicine, hormone therapy needs to be used appropriately, but it is essential that women in early menopause who are suffering menopausal symptoms should have option for using hormone therapy. As said by Bellat sir, that life begins after 50 years. So right woman, right age, right hormone therapy, right dose, and right route is the thing which we follow which we should follow in hormonal therapy. So these are the reference from where I have collected where I have made the slides and collected the data. So I thank sir for giving me a chance. I hope I have finished in 15 minutes, Sonia. Hello?
Hello, am I audible?
Yes,
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 sir.
sir. I'm audible, sir.
Sir, 15
Thank you,
ನಿಮಿಷದಲ್ಲಿ ಮುಗಿಸ್ತೀನಿ
Sanjana,
ಅನಿಸ್ತು.
for nicely covering the topic in the very limited time. Just to summarize your talk, in the beginning only you have told past usage and current usage, which is very, very important. One should know that what we are practicing, and one should know that what we are supposed to practice now. And the organ involvement, particularly CVS benefit, breast and bone, and benefits and side effects also you have covered very well. Types of hormones to be used and indications for the treatment. This is very important. And you must select your case. If you fail to select the right case, even if you give tons of hormones, it is not going to be benefited. And risk is another very, very important. Always you observe for the risk and criteria on which criteria you are going to. And for all hormonal treatment, minimal investigation is a must. Never give hormones without minimal investigations. Minimal, I mean, look for anemia, look for their lipid profile, look for their other coexisting diseases. And follow-up is very, very important, as you rightly told, every 3 months and annual. And contraindications must be kept in mind, particularly the absolute contraindication. And one should know when to stop, because you should not go on giving. And now earlier it was only thought that 3 to 5 years can be given. Now a lot of literature has come where you can continue for almost to 10 years also. And you have rightly highlighted the route of administration. Myself being a dermatologist and a gynecologist, I prefer a dermatological route. Transdermal is where the side effects are very, very minimal. But till now it has not become very, very popular in India. We should make it a popular. And one thing what you should realize is that if you have selected a right patient, if your drug what you have used is a correct one, patient will be symptom free. And once the patient is symptom free, they will think that you are God, because their symptoms are so bad that they disturb their whole life. They go into psychological problems also. I think symptom relief and more so urogynecological problem, which the woman never tells you, that if there is an improvement in the, particularly you ask at every visit, particularly the symptoms which she has not told you, you ask her now, that she will tell, this was my earlier symptom. Now with the drug, this symptom has subsided. I think she has covered wonderfully. And a word about Indian Menopause Society. Indian Menopause Society is a very, very popular society. Lot of work has been done in India. I request all of you to become the members of Indian Menopause Society. And Indian Menopause Society is sending you a journal once in 3 months, once in 6 months, with wonderful article. And she has concluded her talk with a take-home message. I think we should remember, right. If everything is right, the woman can lead a happy life, because life expectancy has increased a lot. Women are living longer than men, and we want good mothers in the house who are the head of the family. I think if the mother is fine, whole family will be peaceful. With these few words, I thank Sanjana for a wonderful talk. Can we go to the next speaker? And the questions, please put into question box.
Yes.
Dr. Rajeshri will take up. Okay? Please
Yes.
be at the end for the questions. Now we have the next speaker, Dr. Rachana. And you know that again, Dr. Rachana is one of our committee chairperson who was happy to grab the chairperson, because the meeting was held in Tumkur only. And when there were selections were there, then we have given her the medical disorders in pregnancy, and she conducted so many wonderful programs. At Tumkur, they had a wonderful one-day full session on the medical disorders of pregnancy. Then other day when I talked to her, I told her, you take up a simple topic, which is very beneficial to all the practitioners day in and day out. Hypertension is such a problem. Hypertension is such a common problem. And when we are with the severe hypertension, we are in lot of confusion. What to do, how many drugs to put, how many combinations to put, when to intervene, when to do cesarean. I think she has accepted this topic. I request her to go ahead with her talk, the management of severe hypertension, restricting to the management part only, because we know that when to say that it is a severe hypertension, and we know that when it is a mild hypertension. With this little adding about the laboratory investigations which are essential and highlighting the management, I request Dr. Rachana to start her talk.
Yes, sir. So thank you, sir. I thank you for all the opportunity that you have given me. I also thank Team KCOG, Dr. Bellat sir, Vidya ma'am, and Sonia ma'am. I thank my greetings to Dr. Kiran sir and my great support, Dr. Bharti Rajshekar ma'am and Dr. Rajashri Paladi ma'am. My greetings to you both too. And with this, I take the opportunity and I'll just share the screen, sir.
Arun sir, could you just mute others?
First slide. Arun,
Yes, sir.
can you help her for the slide?
I had already checked, sir. Why is it not going?
It's
One
visible, ma'am. Reference.
Once again, reopen, madam. Close it.
Reopen, ma'am.
Press escape and then close it and reopen.
After this talk, I request Dr. Bellas to conclude because he is very much fond of hypertension.
No, we have to give some feedback on use of hypertensive drugs. That's the message.
After her talk, you can just conclude, sir.
Oh, now go for slideshow.
Yes, yes, sir.
But you are directly going in the last few parts. Select that. Go back again. Escape. Your slide is selected wrong one. Go to the first slide.
I don't know what is happening. I had already checked, sir.
No, ma'am. Just press escape.
You just escape and go to the first slide.
I'll just get back, sir. Just a minute. Sorry for
I will
the
stop once again, ma'am.
ಬಂದರೆ ನಾ ಅದಕ್ಕೆ ನಮ್ದು ಕಾಲ್ನಾಗಿದ್ದೆ ಅದಕ್ಕೆ ನೀವು
ಇದು ಬಂದಿತ್ತು ನಾನು ಫೋನ್ ಮಾಡಿದ್ದೀನಿ ಸರ್ ಕಟ್ ಮಾಡಿದ್ದೀರಿ
ಇಲ್ಲ
Yeah, you can start now.
Okay, ma'am. Slideshow. No, ma'am. It's coming same.
Madam, you straight go to the screen and click the slideshow. Start from the beginning.
Yeah, actually, I did try, sir, but the slides are just not moving.
Madam, can you give me access?
Yeah, I'll give you the access.
No, you are there. You move on the slide. Fourth
Yes,
slide.
sir.
You directly
Yeah.
go to the fourth slide.
Yes, I think it's moving now, sir. I'll just start.
You can go to the
Yes,
start
yes.
Yeah.
here.
Okay. So today I'm going to be talking about management of severe hypertension. So we all know that hypertensive disorders in pregnancy have been classified as gestational hypertension, preeclampsia and eclampsia syndrome, chronic hypertension of any etiology, and preeclampsia superimposed on chronic hypertension. But I'm going to be talking only on severe hypertension. We all know that severe hypertension is defined as when systolic blood pressure is more than or equal to more than 160 millimeter of mercury, with or without diastolic blood pressure more than 110 millimeter of mercury, when recorded or measured on 2 occasions 4 hours apart. We call it an hypertensive emergency when there is persistent severe hypertension that can occur antepartum, intrapartum, or postpartum, and is defined as 2 BP values when you record more than 160 by 120, which is taken around 15 to 60 minutes apart. But if you have a single value of very high BP, you need not take consecutive measurements. So how do you say that it's a severe preeclampsia? One thing we should know that earlier we had mild, moderate, and severe, and there were no definitive criteria to call it as a moderate one. So for that, we only have now non-severe and severe. So with the high BP of more than 160, 110, if the patient has a presence of proteinuria, proteinuria need not be present. It can be present or absent. There can be headache, visual disturbances, upper abdominal pain, oliguria less than 30 ml per hour of urine output, even a single convulsion, you call it as severe hypertension, and creatinine more than 1 milligram per deciliter, thrombocytopenia less than 1 lakh per microliter, elevated liver enzymes, presence of fetal growth restriction, presence of pulmonary edema, and if the onset is very early gestational age, then you name it as severe preeclampsia. So what is our goals of management? Our main aim is to prevent the maternal complications such as eclampsia and HELP, and we aim for a good neonatal outcome, and we have to restore the health of the mother during her puerperium. So we come to the management. So firstly, once you diagnose the patient has a severe hypertension, you've seen her BP is very high, admit her immediately, initiate the pharmacotherapy within 60 minutes after diagnosing in order to decrease the incidence of severe maternal morbidity, lower her BP gradually because you want to avoid the cerebral ischemia and adverse perinatal outcome. And your target BP that you have to achieve is around 134 by 85 millimeter of mercury. So we all know that when during the 1990s, women with severe hypertension were usually delivered irrespective of her gestational age. But presently, our aim is to stabilize the mother with oral and injectable antihypertensives, assess her gestational age, assess the gestational age of the fetus, whether it's a viable pregnancy, whether she's in preterm or whether she's in term pregnancy. And if once the mother is stabilized and if the baby is a preterm fetus, then you can manage her expectantly so that you can improve a neonatal outcome, but you are not going to compromise on the maternal safety. So what are the first line drugs that we use? We use labetalol, nifedipine, and hydralazine. So all these 3 agents are found to be equally efficacious. And there have been RCTs which have done where nifedipine and labetalol, which we commonly use, are found, neither of the drug are found to be superior, and nifedipine reduces BP more quickly. So one thing we should know that we should know what are the side effects of labetalol and hydralazine and nifedipine. So labetalol, if you want to see, this is the suggested titration for antihypertensive therapy for an urgent control of hypertension. So as labetalol IV can be given, which is one, before giving, you have to see to that the mother doesn't have any cardiac problems or she's not a severe asthmatic or asthmatic patient. And we should know that labetalol causes bradycardia. So you have to continuously monitor the mother before initiating the treatment. So you can give a 10 to 20 milligram of IV stat. Then every 30 minutes, you can go on raising the dose. 10 to 20 milligram stat, then you increase it to 20 to 40 milligram. Then then again after 30 minutes, you can increase to 40 to 80 milligram until you get a good control of the blood pressure. If you are using nifedipine, you can give 10 milligram stat, then repeat the dose after half an hour, then wait for 1 hour. If the BP doesn't fall, you can repeat again after 1 hour. For the next 2 hours, you can give 10 milligram every hourly. Methyl dopa is not the drug of choice for emergency, severe hypertension. What you can do is, if you have only methyl dopa, because why methyl dopa is not the choice is because it has a delayed onset of action. So if you have, you can give 1000 milligram of methyl dopa. Hydralazine, you can give IV 5 milligram stat, then every 30 minutes, you can top up 5 to 10 milligram. This is one. And we have certain algorithms that have been given by ACOG where we use combination of labetalol and hydralazine. And with this, we have to achieve a BP which should fall to less than 135 by 84. So here what we have is labetalol, you give 20 milligram IV over 2 minutes. Then with labetalol, there will be a fall in BP. You just need to wait for 10 minutes, check our BP again. You can top up with 40 milligram IV. Then again, wait for another 10 minutes, recheck our BP. If there is no fall, then you can administer 80 milligram IV. So with 3 doses of labetalol, there is no fall in BP, then you can go ahead with hydralazine. And once you give hydralazine 10 milligram, and then you wait if for 20 minutes and the BP does not fall below, you have to involve the intensivist and maternal-fetal medicine consultant and also anesthesiologist. So with this is one therapy. And if we go for hydralazine as the primary drug, if we start, here again, you're giving 10 milligram, 5 to 10 milligram IV over 2 minutes, then repeat after 20 minutes and give hydralazine another dose of 10 milligram. You should note that only 2 doses you are giving hydralazine. Then you're going to labetalol 20 milligram and repeat after 10 minutes, 40 milligram. And if the drug does not work, then again, you have to involve the other specialists. One thing you have to note that BP should be monitored every 10 minutes for the first 1 hour, then every 15 minutes for the next hour, and the third hour every 30 minutes, and every hour for the next 4 hours. Simultaneously, you have to monitor the fetus. So in case you're using nifedipine, here the nifedipine, this is the ACOG guideline where it says you give oral nifedipine 10 milligram, then repeat a BP after 20 minutes. And if there is no fall in BP, you give 20 milligram, then again repeat the BP. If it doesn't fall, you give 20 milligram after 20 minutes. If after giving 3 doses of nifedipine, that's almost you're giving 50 milligram here. So you simultaneously see if the mother has tachycardia, how comfortable she is, whether she has hypotension. Then you start her with IV labetalol. With labetalol, if she doesn't, again, the protocol, that involvement of all the other specialists needs to be involved. So in case, if these drugs don't work, then we have to go for second line drugs, that is the beta blockers, prazosin, and you can start an NTG drip. Here, we are not using magnesium sulfate, is not recommended as an antihypertensive agent. Here, we should use it just as a seizure prophylaxis because she's still in a severe hypertension. So you can start Pritchard's regimen. You just give 4 grams IV after dilution with 12 ml of distilled water. You give over 10 to 15 minutes of time. Then you can give Maxelf 10 grams IM, 5 grams on each butter. Or you can give as a continuous infusion of 1 to 2 grams per hour. You can give it as a prophylaxis for seizures. So now that we know that, we'll assume that the patient is stabilized with IV agents, and now we are going to, this is the maintenance dose. In maintenance dose, what happens is you can give oral labetalol, nifedipine, and methyl dopa. Labetalol you can give up to 1200 milligram. So the patient can be given 100 milligram twice daily or thrice daily, up to 300 milligram thrice daily or QID. So that accounts for 1200 milligram. Nifedipine can be given 10 milligram BD TID up to 30 milligram TID because the maximum dose will be 120 milligram. Methyl dopa you can give up to 2250 milligram, but unfortunately it's presently not there in our Indian pharmacy. So this drug you can give up to 750 milligram QID. So there are certain additional recommendations where you can give continuous infusion of labetalol. You can give sodium nitroprusside for extreme emergencies. And once we know that the BP is, I've already mentioned about how to monitor. You have to have baseline while you're doing this, you already would have had a baseline investigations of complete hemogram. You have to continue monitoring urine protein, platelet count, LDH, liver function test, serum electrolytes, and serum during the acute phase. You should have the serum creatinine, ask for fundoscopy, and if mother has certain cardiac symptoms or pulmonary symptoms, ask for a 2D echo. If possible, you can get a bedside ultrasound for the fetus, and continuous fetal monitoring can be done. So now that we assume that the lady has been stabilized, so you plan for a delivery. How do you time a delivery? So with the advancement of the feto-maternal surveillance and adequate control of BP with pharmacological drugs, and in the absence of any complications, we can have an expectant line of management depending on the gestational age. If the fetus is in a pre-viable stage, then you can discuss the termination of pregnancy. If it is in a viable period to 33 weeks, then expected management should be considered in a hospital where preterm infants and sick mothers can be managed, and steroid prophylaxis should be considered. If it is between to 34 to 36 weeks, we have insufficient evidence to recommend for or against expected management, but you can initiate delivery because it will benefit the mother, but neonatal risk should be discussed if steroid prophylaxis is not given. So if the lady is term, just go ahead and deliver her. So what are the indications of delivery if the lady, we have been managing her, having an expectant line of management, and she's less than 34 weeks of gestation? You have to look for the maternal and fetal signs and symptoms. If the mother develops at any period of time, if it develops any signs and symptoms of eclampsia, or if there is an deterioration in a renal function, suspected abruptio placenta, pulmonary edema, you just go ahead and deliver her. And if there are any fetal signs where you're monitoring her during the expected management and the BPB falls less than 4 or equal to 4, on 2 occasions 6 hours apart, then you deliver. And if the estimated fetal weight is less than 5th percentile, and you're having a Doppler study monitoring, and there's a reversal of the end diastolic flow, severe oligohydramnios, fetal growth restriction, and in case of fetal demise, we have to plan for a delivery. So what's the mode of delivery that you would want to do? Is it a vaginal delivery or a cesarean delivery? You have to individualize every case. It should be an early delivery is the key. So based on whether the cervix is favorable, you have to plan. If it's an unfavorable cervix, plan for an operative delivery. Continuously monitor the lady. You have to have a proper consent. Catheterization will already be there. Get her coagulation profile done. Have a proper cross-matching and components ready, and then aim for a delivery. So now that we have delivered the lady, we have to do a surveillance. Proper postpartum surveillance is required. How do you do? See, it is necessary to prevent additional morbidity as hypertension or eclampsia can still develop postpartum. So we have, as an inpatient, you have to measure her BP every 4 hours after delivery until she's stable. And at 48 to 72 hours, you repeat the blood count and renal function test and liver function test, and see if they're all, the parameters are well maintained. Try to avoid the use of NSAIDs in these women, and do not discharge the patient until the BP is well controlled for at least 24 hours. And as an outpatient, you should call her back. Once you know that BP is controlled, you put her on antihypertensive agents. You send her, you have to tell her all the signs and symptoms of eclampsia, tell her all the warning signs, advise her, and ask her to come back within 3 to 5 days. Again, see her within 7 to 10 days. And you can give her pharmacotherapeutic agents such as beta blockers. No pharmacotherapeutic agents are antihypertensive agents are contraindicated in lactating mothers. You can give for good control beta blockers, calcium channel blocks, AC inhibitors too can be given. So now that I come to the last part. So before sending her, you have to tell her what is the risk for her in future pregnancies. So you have to tell her if she has had a gestational hypertension, her risk is around for any kind of hypertension, it will be 22%, and chances of preeclampsia will be 7%. So there can be a cardiac adverse event for her. Chances are about 1.5 to 3 times, and stroke is about 1.8 times. If she's been a patient of preeclampsia, then she has 20% chances of getting hypertension, preeclampsia 16%, and cardiac adverse effect 1.5 to 3 times, and stroke 2 to 3 times. We all know that these patients are at high risk for cardiovascular disease, diabetes mellitus, stroke, and venous thromboembolism, and vascular dementia and CKD. So we have to adequately counsel them before we send her home. So with that, I conclude my talk, and thank you, sir.
Comments from Dr. Bella.
Very nice presentation, Madam
Thank you, sir.
Rachna. Yeah, but just want to add up
Yes,
on the.
sir.
See, I think there are few questions by Dwarkanath before that in the chat box.
We'll invite Dwarkanath also.
Okay, so I just want to add on, which
Yes, sir.
antihypertensive we should select because the advancements are there. And in the era, we had done a cradle trial in Asian population, and the Phoenix trial is done in European, and also a trial done in North American study. That, once that is a definite preeclampsia is there, the continuation of pregnancy is just between 3 to 4 days in general. But one advantage in the preterm, salvageable baby, I'm talking, not very early preterm, there the early delivery, very early it is not recommended, but early preterm and late preterm, definitely delivery, you are giving a healthy baby to a neonatologist. That is one part. And the second thing is the Doppler will help you which antihypertensive to choose. If there are Doppler abnormalities are there, especially umbilical artery Doppler is abnormal, you better choose labetalol rather than nifedipine.
Yes,
Because
sir.
labetalol is an alpha and beta blocker, whereas the nifedipine, it causes further tachycardia and there are associated problems. So when there is abnormal Doppler, we should prefer labetalol over the nifedipine, of course. And another thing is, whenever we have now severe hypertension, we are now also, Dr. M.G. Remat in Belgium, we are doing this SFIL to PLGF ratio.
Yes,
Our
Yes, sir.
hospital equipped. Rachna, that is one thing which guide you whether should I give the patient a conservative treatment or we should deliver her, because this SFIL to PLGF ratio, if it is more than 38, it indicates that there is a preeclampsia. But when it is more than 84, you need to deliver. Otherwise, she may have an abruption or intrauterine death anytime. So this SFIL to PLGF ratio will guide the management of severe preeclampsia. We have moved away from all those criteria of proteinuria and other things. So slowly we are coming to the angiogenic and anti-angiogenic investigations.
Yes, sir.
But
Now present.
till that era, we get to every place we need to look at. But please understand, magnesium sulfate plays a vital role in severe preeclampsia. Before giving an antihypertensive, first we should start with magnesium sulfate, because once he throws a convulsion, her death rate increases by 10%. 10 times it increases. So please understand that postpartum hypertension also can come up. And it is also that one of the prognostic indicator that when the hypertension disappears postpartum, if it is less than 12 days, the less likely repetition in the next pregnancy. But if it persists up to 12 weeks, that means this patient is likely to get her hypertension in the next pregnancy. And one important message we should give them is, if they are obese, they should reduce their weight, because higher the BMI, higher the incidence of recurrence in the subsequent pregnancy. Barring that, Rachna, the presentation was very well covered, but we should talk about the atypical preeclampsia. We do not include them as it is in the gestational hypertension, but there may not be proteinuria, but hypertension with the severe symptoms, it is included as preeclampsia. And also the help components, thrombocytopenia and other components are included in this atypical preeclampsia. Thank you very much.
Thank you, Thank you.
Thank you, sir.
Just a word about Dwarkanath. Dwarkanath, can you join? And I think he has brought up some issue. Dr. Dwarkanath, can you please unmute Dwarkanath? Arun.
Hello, sir. Namaste, sir.
Yeah, please. I think you have brought up about the complication.
Yeah,
Can you-
yes, sir. Actually, nowadays it has been proved these preeclampsia patients are more prone for the cardiovascular events, especially peripartum cardiomyopathy and coronary artery disease.
Yes. Yes,
I
yes.
want Bellad sir to give some more
Yeah,
insight.
actually,
And before that,
Dwarkanath, one thing
Yes,
is
sir. Namaste, sir.
in Namaste, in every pregnancy, there is some
Yeah.
amount of diastolic dysfunction. So
Yes, sir.
we have done this study on diastolic dysfunction in preeclamptic versus non-preeclamptics. So
Very nice, sir.
this diastolic dysfunction is exaggerated in preeclamptics compared to the
Yeah.
normotensive. So
Yes.
there are factors why certain patients of preeclampsia only develop peripartum cardiomyopathy. But there is a signal. If you read, there is a American cardiology article, LACC. I can share with you now immediately after this webinar that says
Yes.
that actually the stimulus or the trigger for the preeclampsia comes from the heart itself. That is what they are saying now, and that is why and there is also thinking of going on peripartum cardiomyopathy. Bromocriptine they are trying to use in peripartum cardiomyopathy.
Yes,
And
sir.
another question also you raised in the chat box is that the neuroprotection of magnesium sulfate. This has to be used with pregnancies of less than 32.
Yes, sir.
yes, Rachana, would
And
you like to add?
yeah,
Rachana, would you like to add about aspirin?
Sir, but here we are talking only about severe hypertension.
yeah, that's not
That's why I
prevention.
didn't.
We are not
Only
talking.
thing is I would like to stop aspirin, of course, when I would plan for delivery. But usually it is usually acute, no, sir. So
You know
once,
that every sonologist, when
Yes.
you have sent a patient of hypertension to them, they give a suggestion that every patient should be put on 150 milligram of aspirin.
yes, sir. You can start as early as 12 weeks, sir.
Yeah.
And I was just wanted to ask Bellad, sir, this SLGF
No, this
ratio.
question will continue, Rachana. Question will continue.
sir.
One more speaker is there. Thank you very much for a nice presentation. You have given a
Thank
very
you, sir.
nice brief account of the whole severe hypertension, and you have covered almost all the guidelines also. Just a word about methyl dopa. See, methyl dopa ruled for half a century.
Yes.
50 years, methyl dopa was the only drug. All these drugs came after 50 years. And now methyl dopa has gone back because all these new drugs are excellent and they have got a beautiful mechanism of action. And
No, sir, I want to tell the companies are not manufacturing because this drug will not give them the more profit.
More
profitable. That is the
Yeah, that is the main reason, because still it can be used in a postpartum hypertension.
Still you can use it. That's what I want to add. Thank you, Rachana, for a wonderful talk.
Thank you, sir.
Now I request Arun, please put up the biodata of Dr. Shubha. Yes, it's my pleasure to introduce the third speaker. With great difficulty, we got Shubha Rao as the speaker in the last minute, and she readily agreed for the talk. And I was mistaken that she is in Manipal. She has clarified me that she is no more in Manipal. She is in Bangalore. Thank you, Shubha, for accepting our invitation. She is MS DNB Fellowship in Reproductive Medicine and Surgery from Mahe, Fellowship in High Risk Obstetrics from Edinburgh. And she has got a lot of achievements. Because of the lack of time, I will just mention few of them. Lead consultant at IVF Access Bangalore and UFOXY Kaminira Orator recipient in 2022 and panelist in many of the CMEs and conference. And her area of interest is IVF. I think she has selected the topic of oocyte freezing. Shubha, you can start your talk. And if Vidya Bhatt is here, she can listen to her and she can give her comment at the end of the talk. Dr. Shubha.
Yes, sir. Am I audible, sir?
Yeah.
Sir, I'll start sharing my screen, sir.
Yeah, we can see.
First of all, a very good evening to everybody present here. A big thank you to Dr. Hiremat sir, who has given me this opportunity to speak. And I think I went back on my PG days because I heard Bellet sir. He is my professor in my PG days, and he is the reason what I am. I mean, I am a PG because of him. So he has taught me so many things. And when he was talking about hypertension, I've gone back on those PG days. And I hope he remembers me, sir. You remember me, right?
Yeah, definitely. I could see that
Yes.
immediately. Thank you
Yes.
so much.
Thank you so much, sir. It's so nice to see you on the same platform. I consider it an honor. And also a huge fan of Vidya Bhatt ma'am. Who doesn't know Vidya Bhatt ma'am? And also thank you so much, Dr. Sonia, and also Arun sir, who has helped me with all the doubts that I had during this time. I'll start with my presentation. So it's about oocyte free. So let me start. Hello? Am I audible?
You can
Yes, continue.
Yes.
Yeah,
So
please, all of others mute. Arun, see that everyone is muted.
You mute everyone.
Yes.
Yeah,
So let me start off with with my presentation with this slide. It is not in the stars to hold our destiny, but in ourselves. So what am I going to talk about are the indications, the procedure, the safety, and the statistics and the conclusions. So why do we need this? So fertility preservation basically for young cancer patients, fertility extensions for social reasons, for better matching and quarantining for the egg donation recipients, for maternal donor eggs for girls diagnosed with Turner syndrome, and increased and safer chances of pregnancy for IVF with ethical objections to embryo freezing. So fertility preservation is defined as the use of available technology to help the individuals retain their fertility or ability to procreate. So the main indication is for malignancy, which I'm going to elaborate a little bit more. So there is an advance in the diagnosis and treatment of cancers have led to high cure rate and longer survival. Nearly 1 in 12 cases are detected before 40 years of age, and survivors have to face infertility or early menopause. More females delaying motherhood to 30s and 40s, and increased demand for fertility preservation. So what are the factors to consider? The desire of the patient to retain fertility potential, their age, obstetrical history, family history, and history of infertility, extent of the patient cancer, and optimal cancer therapy should always supersede fertility preservation. So here is a forgotten female. So studies have suggested that only half of the oncologists discussed fertility preservation with their patient. The ASCO guideline has said that as part of the informed consent prior to therapy, oncologists should address the possibility of infertility with patients as early in the treatment planning as possible. The fertility preservations in patients with cancer, the recommendations basically have told us that healthcare providers caring for adult and pediatric patients with cancer should address the possibility of infertility as early as possible. They should refer patients who express an interest in the fertility preservation to reproductive specialists, and also should preserve the full range of options. Fertility preservation approaches should be discussed as early as possible before the treatment starts. So this is basically the chart when a patient is diagnosed with cancer, starting from the clinical care team where they have the information provision, referral for a fertility preservation consultation, where the patient is assessed, general health risks, age, ovarian reserve, all of that is calculated and the options are given. The decision aid is given and interventions have been done. And after that, follow-up followed by their reproduction potential. Risk of infertility in women. Chemotherapy and radiotherapy may induce premature ovarian insufficiency in women. Ovarian damage is drug and dose dependent and it increases as the patient ages. Radiotherapy may also affect the uterus, leading to reduced vascularity, myometrium damage, and hormone dependent insufficiency. Fertility may also be impaired by surgical removal or damage to reproductive organs. So here is a normal ovarian reserve as it declines at a normal rate. Now, when there's a cancer treatment, you can see the acute drop after the cancer treatment. So this is acute failure, ovarian failure and premature menopause. So this basically tells us that these two conditions, they have a risk of occurring in cancer patients who have undergone treatment. Malignancies in young women. Damage to the ovary following cancer therapy is very age dependent. Exposure to high doses of alkylating agents and ovarian radiation are associated with an increased risk of both acute ovarian failure and premature menopause. Future fertility prospects are identified as a specific anxiety for young women and their parents. Age plus a decade equals the reproductive age following chemotherapy. So this is one of the studies where the total number was 1,041, where 620 of them received chemotherapy, and this is the numbers 8, 10, 9, and 10%. They had acute ovarian failure in Hodgkin's, non-Hodgkin's, breast, and GI cancer. Acute ovarian failure increased significantly with the age, and in those not reporting acute ovarian failure, the incidence of infertility was at least 40% in those with breast cancer and Hodgkin's. The probability of early menopause was at least 25% at age of 30 years and increased significantly with younger age at diagnosis. So the agents and its toxicity, that is also related. So high risk, that is greater than 80% risks, are cyclophosphamide, busulfan, mephilan, procarbazine, and ifosfamide. Intermediate risk, that is 20 to 80%, are thiotepa, cisplatin, carboplatin, and carmestin. And low risk, that is less than 20% risk. So these all percentage are very important when you're counseling a patient and informing them about their risk of infertility or their future prospects of infertility. So what are the options for preserving fertility for women with cancer? Cryopreservation of ovarian tissue, cryopreservation of embryos, cryopreservation of oocytes, in vitro maturation, whole ovary preservation, ovarian suppression, transposition, and fertility-sparing surgical procedures. I won't be talking about all, but just a few lines about each of them. So ovarian tissue cryopreservation as an alternative option. Fertility preservation alternatives in patients at high risk of ovarian failure when there is no time to stimulate them and retrieve mature oocytes. So this is an ongoing, it is happening all around the world. 86 reported live births, that is in one of the studies, and 9 ongoing pregnancy, but it is still considered experimental. And it is only performed in a few centers worldwide because there's a separate set of media that we need to cryopreserve this ovarian tissue. Ovarian tissue can be retrieved either by ovarian biopsy or oophorectomy, wherein the primordial follicles are retrieved from the ovarian cortex. Since the ovarian cortex is grafted as an avascular transplant, follicular depletion may occur during the first days due to ischemic damage, and OTC is restricted to malignancies that do not affect the ovary directly. Histological analysis may be helpful, but not enough to rule out the possibility of contamination of malignant cells within the tissue. So the technique of ovarian cortical tissue removal, probably 1.15 mm thick biopsy of the ovarian cortex, where you can find primordial follicles and transport it as immediately possible to the lab and freeze it off once you confirm there are primordial follicles in that bit of tissue. What is the decision for ovarian tissue cryopreservation? Now, age is a huge bar. It's less than 35. I have mentioned few studies have told take it up to 15, but there have been studies that have taken up to 35 years of age also. It's a planned decision explaining the estimated risk of ovarian failure related to the planned treatment, detailed explanation in terms of success of the intervention in the future, and oophorectomy that is only in selected cases. Reimplantation of the ovarian tissue, either orthotopic or heterotopic, in the pelvic cavity is likely to be a better area for follicular development in terms of oxygenation. Restoration of endocrine function is possible with heterotopic ovarian transplantation. Orthotopic transplantation consists of implanting the ovarian tissue inside the peritoneal cavity into the remaining ovary or the ovarian fossa or into the broad peritoneal ligament, whereas heterotopic transplantation consists of implanting the ovarian tissue into locations other than the peritoneal cavity, such as the subcutaneous abdominal wall beneath the peritoneum, the rectus muscle, and the forearm. In orthotopic, obviously, it has some advantages. As has been well documented, it can lead to live births even through spontaneous pregnancy. The recovery of endocrine function is observed in over 95% of cases, begins 2 to 9 months after grafting and holds its functionality even up to 7 years. In heterotopic, has specific strengths such as its simplicity, cost effectiveness, less invasive, feasibility when pelvic adhesions are present, not allowing the orthotopic transplantation. On the other hand, spontaneous pregnancy is not possible. It's basically for its endocrine function. So it's a small diagram of ovarian is orthotopic, and this is the heterotopic transplantation. There have been successful cases of orthotopic ovarian transplantation as well. So basically, here is a woman who wants to preserve her ovaries or preserve her fertility. There are so many options. Either we can go for an ovarian cortex biopsy, preserve it, and then probably do a transplantation later on and see whether it has its endocrine function, stimulate her, or probably competent oocytes, do an IVF cycle and produce an offspring. Or at the same time, ovarian cortex, the same preservation, get the primordial follicles, do an IVM, grow it into competent oocytes, and then a possibility of an offspring. Or if she has enough time for stimulation, stimulate her, get the eggs out, then probably form an embryo by either form an embryo or freeze her oocyte. So there are various options when a person is diagnosed with cancer and the next whatever the future for her is. Now going on to embryo cryopreservation. Now embryo, obviously, this requires an egg and also a sperm to be involved in this. This is an established option for fertility preservation, requires medical stability, time, and partner donor sperm, and adequate ovarian reserve. Women should be informed of center-specific expertise and live birth rates. They should also be informed that success rates after the cryopreservation of embryos at the time of a cancer diagnosis may be lower than in women without cancer. So ovarian stimulation in cancer patients undergoing fertility preservation treatment, GnRH antagonist protocol is recommended for its feasibility in urgent situation, short time, and safety reasons. In urgent fertility preservation, random start is also a very feasible option. Double stimulation can also be considered for urgent fertility preservation cycles. And in ovarian stimulation for fertility preservation in estrogen-sensitive disease, the concomitant use of letrozole is probably recommended. So timing of this procedure no longer depends on the menstrual cycle, and stimulation can be initiated with less delay compared with old protocol because of the urgency of the situation. So how effective are non-conventional ovarian stimulation protocol? That is the random start protocol that we have. This is the most updated and comprehensive review. The study shows that starting this stimulation during any part of the menstrual cycle should be an optimum for all the poor responders, generally infertile population, and patients undergoing oocyte freezing. They also found that performing a duostim protocol could achieve a high number of retrievable M2 oocytes in a single menstrual cycle in poor responders as well. Going on to the evidence on safety. Safety basically tells us that is it safe to wait for another 10 to 11 days? Well, of course, that depends upon the oncologist's opinion about how emergency that we need to start a disease. So patients who undergo ovarian stimulation, they show no increased risk of death, shorter disease-free survival or recurrence. Post-treatment pregnancies also do not affect survival or recurrence risk. And because of the aromatase inhibitors can also keep the peak estradiol levels within the physiological levels. Moving on to the oocyte cryopreservation. Oocyte cryopreservation should be offered also as an established option for fertility preservation. Women with a partner should be offered the option to cryopreserve unfertilized oocytes or to split the oocytes to attempt both embryo and oocyte cryopreservation. Should also be informed that success rate after cryopreservation at the time of cancer diagnosis may be lower than in women without cancer, likewise as embryo cryopreservation. In vitro maturation of oocyte is still something to be studied. It should be regarded as an innovative procedure due to lack of studies on long-term safety. It requires specific expertise and should only be performed when oocyte cryopreservation is required but ovarian stimulation not feasible. And IVM after X5O extraction can be offered as an experimental procedure. GnRH agonist during the treatment basically works like this. A normal premenopausal ovary can have a low-level recruitment of primordial follicles. You give cytotoxic chemotherapy. There is oocyte toxicity due to which there is decreased estradiol. Because of the decreased estradiol, there may be increased FSH, increased follicular recruitment, and because of that, more oocyte. So at that time, if you give GnRH agonist, this part of the cycle may not work, and in terms, we may probably save some oocytes. Whole ovary preservation is likely to be more problematic in adult women because of the increased size of the ovaries and difficulty of achieving adequate perfusion and penetration of the cryoprotectant agents. Ovarian transposition or oophorex can be offered when pelvic irradiation is performed. However, because of the radiation scatter, ovaries are not always protected, and patients should be aware that this technique is not always successful. Because of the risk of remigration of the ovaries, this procedure should be performed as close to the time of the radiation treatment as possible. Safety and timing of the pregnancy after cancer. Conventional wisdom is to wait until patients gets through the period of highest risk recurrence, receives optimal therapy, no evidence for increased risk of disease recurrence, and aside from hereditary genetic syndrome and in utero exposure, there is no evidence of increased risk of cancer abnormality in the progeny. So conclusion of this oocyte or ovarian tissue cryopreservation, it's very complex and difficult issues. Patient preferences are critical in some settings. They address fertility issues upfront, and they also refer to fertility specialists early, and in the event of pregnancy, they do consider high-risk obstetrics. Sir, if I have time, shall I also talk about social freezing, or is it okay?
You have got presentation?
I do have social freezing, but as you said, it could be a little controversial. Do I have time?
You can have social freezing some other time.
Okay, fine.
Full time.
No problem, sir. Thank you. Okay. Then I guess this would be the end of my presentation, and I'll come back again to talk about social freezing.
Okay. Thank you, Shubha, for a nice presentation.
Yes.
The most upcoming subject, I can tell you.
Yes.
And very few are in this field. I think you have selected a very good field so that you can help many people. And as you know that we are not able to control the cancer. Cancers are happening. I think fertility preservation will be the best option for them. I think these techniques must be mastered, and the rate of success also should go in a higher way so that many will get option of this. I think you have covered almost all the things. Is embryo preservation is more difficult, or oocyte preservation is more difficult?
Sir, either is the same, but with oocyte freezing, there'll be more damage because you're vitrifying, and then you're again going to thaw and put the embryo, and then if you're going to
success rate will come down.
Is going to be.
But embryo freezing has become very standard.
Yes,
and
sir.
Results are excellent with embryo freezing.
Yes, sir.
That is the one. I think we have yet to achieve the oocyte freezing success rate more.
Yes.
And
sir.
what about young girls when they have a cancer somewhere in the age group of 15 to 20?
Yes.
What is your option?
So it depends on how severe the cancer is and how soon they need the chemotherapy. Since ovarian tissue cryopreservation is only done in a few centers, including KMC Manipal, so that's a research center. So we do ovarian tissue cryopreservation over there. But if she has the time, it's better to go for ovarian oocyte freezing. But if she doesn't have the time, then she'll have to do an ovarian tissue cryopreservation.
Yeah. Thank you very much. I think Dr. Rajeshri Paladi is waiting for a long time. with 19 chats in her box.
Thank you
Now
so
I
much.
hand it over to Dr. Rajeshri, and I
Yes.
request all the three speakers to be on the screen. And any question is there, the first answer should come from the speaker. And if any of the audience are not very happy with their answer, they can come in. Dr. Rajeshri Paladi, please take over.
Namaste, sir. Good
Namaste.
evening, everybody. And after the extensive talks, very interesting topics as Dr. M.G. Hiremat sir has chosen, and very, very practically relevant topics that we have had for discussion today. I must congratulate all the three speakers for doing a wonderful job and wonderful presentation. Dr. Sanjana, Dr. Rachana, and Dr. Shubha for enlightening the audience with very important clinical relevant points. Many congratulatory notes in the chat box to Dr. Sanjana and Dr. Rachna. And there are some questions which were raised by Dr. Dwarkanath, which has been addressed by Dr. M.B. Bellat sir, as in severe preeclampsia and peripartum cardiomyopathy. What is the correlation and risk factors for postpartum cardiomyopathy? I think this has been already addressed too. And the next doubt was, there's a congratulation for Rachna, and Rachna says, thank you. APLA and severe preeclampsia and its management.
Hema Divakar has put up that question regarding
Hema
APLA.
KR,
Is
sir.
there
Hema
Hema KR.
Hema
KR.
Divakar madam is there?
No, sir.
Hema
Hema KR.
Yeah.
So
I
APLA and
Hema.
severe preeclampsia and its management.
Oh,
Anybody?
that's a quite, it's a topic by itself, ma'am,
Yeah.
when
The
it
topic
comes
is-
to APLA. Severe
Yes.
preeclampsia, I've just now dealt.
Yeah.
Like-
Just to highlight on that,
Yeah.
see, whenever you are treating APLA syndrome, you are just use not only ecosprin, you are using the low
Heparin.
molecular heparin. So please don't stop the heparin after the delivery, because these patients are prone for even postpartum CVT, DVT. So only for a period of delivery time, you can stop that one dose, and subsequently after 6 hours of delivery, you restart the low molecular heparin as well as ecosprin. Don't stop at least for 3 to 6 weeks and continue ecosprin thereafter, because APLA is a challenging one. Postpartum is equally dangerous period. So I hope that is clear with them.
Yes, sir. Thank you very much, sir. This was the point to be noted.
Yeah.
Yeah. There is another question by Dr. Thank you, Bellet sir. There is another question by Dr. Dwarkanath that indications for trachelectomy and follow-up. Do these patients require radical hysterectomy later? I do not know in what context sir is asking this question.
I think this is not relevant for this
Yes.
particular,
Yeah.
and it is
Yes.
for actually cervical cancer.
Cancers.
So we have some other time that needs to be discussed.
Correct, sir. And Rachna has answered the query for neuroprotection and the dosage in the chat box.
Magnesium sulfate.
Magnesium.
It's the same dose as Pritchard regimen, ma'am.
Yeah.
There is no different
Yes.
regimen for it. It's the same thing.
Sonia, yes, Sonia has a question. Maintenance of magnesium sulfate, if not controlled for 24 hours, how long to continue if pregnancy is to be continued?
You are giving neuroprotection only for about 24 hours. That itself will take care. This is with respect to neuroprotection.
No, prophylaxis for the convulsions. If
Yeah,
it is
prophylaxis. Then you have to
prophylaxis
you once you maintain her, if she's not, if she continues to have symptoms, then you have to deliver her. You're not going to continue. You cannot prolong the pregnancy if the seizure prophylaxis is not working for her.
So, but then is there any studies that they actually have a long-term study on magnesium sulfate again? If it is repeat again, we have an episode of convulsion again. Do we start magnesium sulfate?
Sonia, there is
don't
no
think
current
that-
role of intercurrent eclampsia or severe preeclampsia.
Yes, sir.
Please note that.
Yes, sir. Because as one episode of convulsion and magnesium sulfate is started and then discontinued after 24 hours, and if the patient continues pregnancy and there any antihypertensives is superadded to it, and if the patient discontinues that and she has a convulsion again, do we actually have a role again to set back the MATSAL?
First of all, Sonia, the
Yes,
doctor
sir.
must be very, very
Very
courageous.
brave.
Yes.
You should not entertain such things, because if the eclampsia patient you have controlled, and you know that with every convulsion her death chance increases.
Increases.
And the intracranial
Oral
hemorrhage
action.
chance is increasing. So please understand, intercurrent eclampsia is no more permitted. That's a clear message.
Yes, the referral slip always states we don't know whether it is a correct dosage which is given. In a referral hospital, we receive and take patients where it's just documented, but we don't know exactly whether it is the right regime which is started and then shifted.
Pardon? That you can give the basic dose in the beginning in the, from the periphery. Even just IM 2 doses of 5 gram each can be given and sent. That can actually reduce the risk of hypertension.
Yes.
Sonia ma'am, if in case you don't know what has been given, you can still give 2 grams IV.
Yeah, that was
Extra top up you can give 2 grams and then give the maintenance. If you don't know if 4 grams has not been, but you're not sure about whether 4 grams has been given or not.
I think questions are over, sir. The chat box.
Ma'am, I have one question, ma'am.
Rajeshri, one thing.
I have one question for Bellad sir.
Yeah.
No, before that, let me answer on the
Yes.
neuroprotection. The neuroprotection, once you give for 24 hours, you must deliver. Because if you delay the delivery, the neuroprotective effect of the magnesium sulfate also goes. So you are planning to deliver, then you give magnesium sulfate for 24 hours. And that is one thing which should be. And please also note, when you are giving a steroid in our country, don't give betamethasone. We do not have a betamethasone of international standard, where there is a phosphate and acetate combination. But unfortunately, in India, we do not have this combination. So that is why Government of India still recommends only dexamethasone, 6 milligrams, 4 doses.
Yes, sir.
So somebody wanted to ask me.
Sir, I want to ask one question.
Anjana,
Sir.
last question.
Sir, any correlation between prolactin level, preeclampsia, and peripartum cardiomyopathy?
Yeah. That's why I told you bromocriptine is recommended in peripartum cardiomyopathy because of this high level of prolactins. But exact level of this prolactin cannot be shown because the normal pregnancy itself, prolactin level is so much high. So they cannot predict on this. That's why, but bromocriptine is given along with the other treatment with peripartum cardiomyopathy. But this bromocriptine use is still under the experimental.
So they are using that
No, use of bromocriptine is under the experimental. It is still not recommended.
It is under experimental.
Okay.
I think we had an excellent discussion.
Sir, 1 minute. I have a question for Shubha.
Shubha, yes.
Shubha, excellent presentation. What we are looking at is we last in two and a half years, I have seen an adolescent girl coming with a ovarian malignancy. Unfortunately, it had spread to the uterus, and the other ovary was safe. But we did contact at that time the one person from Mumbai, ovarian transplant person who did that. We thought that the migration would help, but chemotherapy even destroys the migrated ovary. What is your opinion on that?
Yes, for those people, I mean, young girls who have already received chemotherapy, they would have already destroyed the follicles. So before starting, I mean, before even thinking of fertility preservation, we should first make sure that she is in no disease recurrence and there is no remission of the same tumor. Second thing is probably see the number of antral follicles that she has, or probably do an AMH and see her ovarian reserve before going to any fertility preservation. Maybe before operating for the ovarian tumor, if we could have thought about fertility preservation in terms of either ovarian cortex preservation or oocyte, that would have been a better option rather than planning after a chemotherapy sessions.
Thank you. After a long time, I saw Shubha Rao on this. Good to see
saw me as last year. I think I saw you, sir.
Thank
The
you.
good news is that
at
least we have some options for treatment in those young girls who are suffering from cancer, and we can play God by preserving the oocyte functioning and all that. Thank you so much.
Yeah, just let me put my last words as a chairperson. I am very happy today that KCOG Yuva has become so interactive and so nice, and nobody felt boring at any time, even though we are reaching to 2 hours. I think the topics what we have selected for each of them, their own committee, that shows that they are very much interested in their committee and they are doing their committee work. And all the three speakers have spoken very well. They are well prepared and they have made their point very, very clear. I think this type of the KCOG Yuva will be there on every month on third Thursday. And Sonia, this time I have come your help. Next time you should conduct your KCOG Yuva on your own. And,
Yes.
And I wanted you to be a speaker this time. And you have told that you will be the speaker next time. You as one of the speaker, and you can take 2 more young people and you can make very, very interesting. I thank Dr. Bellad also for having joined and remained throughout as a dean. That's a very good sign because we all must join youngsters, old people. Then there will be a mixture of knowledge and then there will be a good interaction. And Rajeshri also has put up good questions. I think as a convener, Sonia can say few words and we will hand over to our treasurer for vote of thanks. Sonia.
Yes, sir. Thank you very much, sir, for creating a platform. But then there are a lot of maybe some questions which cannot be taken at the end, probably can be answered offline also if we share the speakers' telephone numbers for those who really want to interact with them. So this kind of platform will have more access to the clinicians as well. Thank you so much, sir. I extremely thank our Dean, KCOG, Dr. Bellad, and also Madam Dr. Vidya Bhatt. And we miss our President of KCOG, Dr. Bharti Rashikar, on this platform. And hopefully she joins our next Yuva platform without fail. And with these words, I also thank the speakers and over to Madam Suman Gaddi for the vote of thanks.
Suman Gaddi, madam.
Yes, sir. Good evening, one and all. Firstly, I would like to thank the entire KCOG team for such a wonderful program and choosing such wonderful speakers and wonderful topics. I thank our chief guest, Dr. Kiran Kurkoti, and the guest of honor, Dr. Bharti Rashikar, for their blessings on us. I also thank today's speakers, Dr. Sanjana Patel, Dr. Rachna, Dr. Shubha Rao, for their wonderful talk and giving us such wonderful guidelines and tips for in their topics, various topics. And I also thank today's chairperson, Dr. M.G. Hiramat, who has chaired the session so well and given us important inputs. I also thank Dr. M.B. Bellad for his valuable inputs. I thank Dr. Rajshri Paladi for taking up the questions. Thank our convener, Dr. Sonia Mandappa. I also thank all the delegates who have logged in, and I thank last but not least, Mr. Arun for providing this platform. Thank you, one and all, and of course, good night, one and all.
Thank you. Good night.
Good
night.
Thank you, sir. Thank you, ma'am.
Yes.
Thank you.
Sonia, happiest person. So thank you very much. We'll see you next month, first week, the KCOG National. And I request all of you to join on the first Thursday of the month, June. Thank you.
Thank you, sir.
Rajeshri ma'am, thank you so much. Rajeshri ma'am, I basically wanted to raise that question only because we are receiving a lot of referrals.
Correct.
Stating that they have given Maxself, but when they reach, they are already convulsing.
Correct.
So it is, we are in a fix whether to give a second shot.
Yeah.
These are all practical points, especially in hypertension. You keep continuing to get all this kind of mix and match kind of protocols and treatment regimes. Anyway, something is done and something is being given and sent. That is a good thing. But as mentioned by Bellad sir and Rachna, that that 2 grams IV given top up, even in spite of whatever dose has been given, and speed up the delivery process. I think
there'll be no referral. They would have referred, ma'am. They'll tell that Maxself has been given, but there'll be nowhere written.
Exactly.
I had 2 people in ICU this week. This Sunday, I was sitting and monitoring. One had cardiac that problem also. She had cough and all that, getting echo done on a Sunday afternoon. It's really.
No, Dr. Archana, that's the reason I put that question. It's
Definitely for intercurrent eclampsia, there's no role, as Sir has mentioned again. I had one particular patient about 5 years back, which was a IVF conception. She was 26 weaker and she threw a convulsion. I really took a chance for her, gave her magnesium sulfate, kept her in the hospital under observation for nearly 3-4 weeks, and then delivered her. When the baby came to a a salvageable weight of 1.2 kg, that is the only case in my entire career I have managed intercurrent.
Ma'am, actually, now
Indeed brave.
I have one patient with me today. Only thing is her Doppler says it's reversal ductus venosus. That's what our postgraduate. This is a challenge now. What to do? Already reversal started. It's anyway. Thank you.
Person to keep doing scan PID for.
Yes, yes. Thank you so much, Dr. Rachana.
Thank
you, ma'am.
Thank you, Rajashri, ma'am.
Thank you, Rachana. Well done.
Thank you, ma'am. Thank you.
Okay.
Good night.
Good night. Good night.
Dr. Kiran Koti is hearing us. Good night, sir. Thanks. Thank you very much for joining us. Arun, sir, thank you.
Thank you. Bye. Good night.
Bye-bye. Good night.
Thank you.